The trial is now resuming with someone who was a consultant paediatrician at the time of June 2015 giving evidence in court in relation to child A and child B. She said she, quote, cannot recall the events for child B's collapse at 12:30am on June the 10th, as it was 7 years ago, and her recollection would be based on the statement she had given to police. The court is shown clinical notes made by her, written retrospectively at 2:40am on June the 10th, 2015. She was called at home at 12:36am and arrived at the neonatal unit at 12:50. She recorded child B, quote, went apneic, stopped breathing, followed by sudden purple blotching of body all over with slowing of heart rate. The consultant says the purple blotching would have been the registrar's account of events relayed to her. The registrar also relayed child B was bagged and tubed and the heart rate went up with adrenaline not required. The consultant noted for her observation, quote, upon my arrival, purple blotching right mid-abdomen and right hand. The baby was pink and active. The prosecution asks, do you have any independent recollection of that now? The consultant replies, no. The consultant relays the various medical observations that were recorded at the time, including blood gases, protein levels and heart rate. The consultant tells the court discussions have been ongoing since the evening of June 9th in the light of child B's twin brother dying on whether child A and or child B had been affected by the mum's blood condition. Consultants at Great Ormond Street Hospital had said they, quote, did not feel the mother's condition would affect the baby in any way, while consultants at Alderhay Hospital suggested further blood tests being carried out. Following child B's collapse, the blood observations taken were good and meant the requested extra tests were held off. Child B was restarted on antibiotics as a precaution. There was still concern her circulation had to return to normal, so the consultant noted more fluid was administered to help with that. The consultant's notes add, spoke to parents, purple discoloration almost resolved, cause. The consultant says from looking at her notes, she was quite puzzled by that as there were 2 question marks. The notes add, stabilised at present, continued antibiotics, nil by mouth, repeat gas and wean as tolerated. The notes conclude for further tests to be repeated at 7:30am at the end of the night shift. Ben Myers KC, for Letby's defence, asks about one area on the clinical notes talked about. Mr. Myers asks about the purple discoloration, and that by the time the consultant had arrived, she had noted what she had seen at 12:50am, and had, quote, almost resolved by the time of the note at 2:40am. She tells the court, quote, I think this was something I was puzzled about, and wondering what it would be. She says other causes were ruled out, as such a rash had come out of nowhere, and had almost completely gone a couple of hours later. She added she was, quote, a little bit confused, and was trying to put in place all the safe things she could to treat child B. Independent medical expert Dr. Evans has returned to give evidence in respect of child A. He confirms he has written 4 separate statements in respect of child A, the latter 2 being clarification on technicalities. The first report was written in November 2017, the second in May 2018. Dr. Evans said he became involved in the case in July 2017 by the National Crime Agency. He visited Cheshire Police where they had concerns about a number of deaths in the Countess of Chester Hospital, which were, quote, unusual and far more deaths than they would expect. The deaths had followed collapses in babies which were otherwise quite stable, and involved collapses where resuscitation attempts were not successful. He said, quote, I thought I could help advise, review case notes and form an opinion that led to the collapses of child A and child B. He said, quote, despite the prompt resuscitation in child A's case, child A had died despite doing very well. He said his job was to look at the clinical evidence. He added that child A was the first case he looked at, and subsequent reviews of other children had reinforced his opinions for the conclusions of child A and child B. He said, quote, a pattern became apparent in the cases, which he described as quite disturbing and quite unusual. For child A, Dr. Evans confirms he had received clinical records for the baby boy to review, and had received statements from Countess of Chester Hospital medical staff for the case. Dr. Evans explains to the court certain medical procedures such as cannulas, UVC and long lines. Dr. Evans said there is a connection between the insertion of a long line and cardiac tamponade, where fluid obstructs the heart and is a deadly serious condition. He added that sadly he was aware of a case which happened in Swansea, where a baby had died as a result of that. He said such cases are where a long line has been in place for several days. Diagnosing such a condition post-mortem would also be relatively straightforward, as fluid would be detected outside the heart. For child A, he had not come to the conclusion that cardiac tamponade was the likely cause of death. Dr. Evans says from looking at Dr. Harkness's clinical notes at the time, the efforts to save child A were, quote, very good standard resuscitation procedures. He added, it is what you would expect in any neonatal unit in 2015. Dr. Evans said, just before child A's collapse, he was in a stable condition. In his report, he had described his condition as perfectly satisfactory. He added, quote, he was as well as could be expected. All the markers of well-being were very satisfactory. He was in air, not needing additional oxygen, heart rate in normal limits, oxygen saturation normal, it had been in the 90s, respiratory rate slightly above normal rate, but that was the only marker outside normal rate. He said child A had survived the most dangerous journey of his life, and although he needed care for feeding himself, he was doing really well, and everyone on the unit would have been really pleased with how he was. Dr. Evans said he had not been presented with evidence of the discoloration as the court has heard through this trial for child A. He said it was not noted in the evidence he had received. He adds, quote, I think the rash in child A's collapse fits together and fits a significant diagnosis of air embolus, injection of air into the circulation. He said, quote, somehow air had got into the circulation. I found this opinion without knowing about the rash and without anybody suggesting or expressing concern of air embolus. He rules out other conditions such as sepsis, a lack of fluids or hypoxia as causes or contributing factors to the collapse. He said he had only one conclusion, that child A had received an air embolus through an IV line. He said with the systems in place and the medical equipment and medical staff being obsessive about making sure patients are not injected with air, there was no way this could have been done by accident. Dr. Evans will be cross-examined by the defence after giving evidence for child B. Before that, independent medical expert Dr. Sandy Bowen has now been called in to give evidence for child A. She is detailing to the court her medical and professional background. Dr. Bowen says she was asked to peer review Dr. Evans' report and was to find whether she agreed with them, disagreed with them, or had additional findings to present. She has also considered other findings from other independent experts in the case. The prosecution asked Dr. Bowen to clarify whether she had also seen a post-mortem report for child A and the reports of Countess medical staff. She confirms that was the case. Dr. Bowen explains child A was, for a baby born 10 weeks premature, a stable baby, on breathing support via CPAP but not requiring oxygen ventilation, and was doing so well that medical staff decided to start giving him some feeds. Quote, if he was unstable in any way, they would not have done so, she tells the court. The UVC placement and long line placement did not have any contribution to child A's death, Dr. Bowen tells the court. Was the stopping of breathing for child A caused by his prematurity, the prosecution asks. Dr. Bowen said it could be ruled out as there were no previous episodes, and caffeine had already been administered to counteract it as a precaution. The discoloration seen, while seen in collapses in other infants, did not explain the pink blotching that came and went in child A, Dr. Bowen tells the court. She says the only plausible explanation for child A's collapse is an air embolus. Dr. Bowen said doctors and nurses are absolutely meticulous in making sure even the tiniest air bubble is not injected by accident into a patient's circulation. She adds that even if air was accidentally administered, there is an electronic pump system which would detect the air and stop the administration. Dr. Bowen explains to the court that could be bypassed further down the line by administering the air embolus via a connector normally used for administering drugs. Dr. Bowen is asked how much of an air embolus would be considered fatal to a child of child A's size. She says that 3 to 5 ml of air per kilogram of body weight could be fatal. She explains child A weighed 1.6 kilograms, around 3.5 pounds. A teaspoon of air? Nicholas Johnson KC prosecuting asks. Well, that is 5 ml of air, so yes, replies Dr. Bowen. Mr. Johnson prosecuting asks, what, in your opinion, killed child A? Dr. Bowen replied, child A was killed by an air embolus. Dr. Evans is recalled to give evidence for child B's non-fatal collapse. He said the collapse was not really likely, as all the markers were satisfactory, and the medical staff had felt comfortable enough to allow the baby girl to be out of the incubator for a short time so she could be handled by the mum. He said that was not something you would do if the child was not stable. He said the two conclusions he had for child B's collapse were smothering or an air embolus. He said the discoloration was a striking feature which had been seen in child A. It arrived and went very quick. He said if the rash was associated with other conditions, it tends to stay. Dr. Evans tells the court the collapse was very similar to that of child A, but what happened was less severe. He said either the volume of air injected was less, or the volume of air in the circulation got there more slowly, or a combination of the two. Asked by Mr. Johnson if there were any other possibilities to the cause of the collapse, Dr. Evans replies, I could not think of anything else. The doctors did a really good job in saving her. There was no evidence of sepsis, problems with the lungs, nothing unusual about the chest x-rays, lungs were full of air, nothing else to explain this collapse, which again was sudden and unexpected. He added, quote, we have heard numerous doctors saying they have never seen this before. I feel I can say the same. It's very unusual. Ben Myers, KC, defending, says Dr. Evans has prepared, quote, a large number of reports over the years, and air embolus feature in a number of them, literally dozens. Dr. Evans agrees. Dr. Evans is asked to explain the features of an air embolus. He adds, quote, an air embolus will lead to a sudden and unexpected collapse. A patient otherwise stable collapses, and by collapse I mean change of colour, stops breathing, reduced heart rate and death. This occurs all of a sudden. There are additional features, and you don't get all of the features in all cases. The two main associated features are unusual skin discoloration and the presence of air in the great vessels. Those are the compounding features which lead to a diagnosis of air embolus. This occurs when there is no other explanation which fits the collapse, and when resuscitation is unsuccessful. Resuscitating patients for doctors is part of our bread and butter, so resuscitating is well known. When that is unsuccessful, it adds to the confirmation of an air embolus diagnosis. Dr. Evans relays one case of a baby who had died in Swansea from an air embolus from what should have been a regular surgical procedure. He said he had not been involved in the report, so was unaware of any discoloration in that baby. He says he has never come across such skin discoloration in a collapse in hands-on experience. That is something I am relieved and pleased about, he said. Mr. Myers, on behalf of the defence, said the diagnosis is one of exclusion, ruling out alternatives until there is one explanation left. Dr. Evans said there is more to the case than that. He said his original conclusion was without knowing about the skin discoloration in child A. He adds that if you discover additional information, that simply firms up your diagnosis. Dr. Evans states that air embolus cases are difficult as there are isolated case reports and the systems are put in place in modern times so the conditions are not repeated. That is not a criticism, that is a compliment, hence there is very little new research, he said. He adds that doctors may be reluctant to spread news of mistakes in cases where there may have been an air embolus. Dr. Evans said he was tasked with investigating a clinical condition, not a crime, when he became aware of the Countess of Chester Hospital case, when tasked by the National Crime Agency. He said the scenarios added up to a, quote, constellation of worries on what went on between June 2015 and June 2016. He adds that in past cases, he has been brought in by police and the conclusion was accidental, so the case was closed with no further police involvement. He is asked about his state of mind in his approach to the cases. He said, quote, "My state of mind was very clear. Let's find a diagnosis. Nothing to do with crime. Let's identify any specific collapse and see if I can explain it. There were occasions where I couldn't explain it, and occasions where I found something deeply suspicious. There were incidents I found disturbing." He was asked to investigate 33 cases in total, with 2 insulin cases later. He said there were 2 babies who were born in unsurvivable conditions with obvious medical diagnoses. He said, quote, "The name LucyLetby meant nothing to me. I didn't know the staff. I was the easiest physician and the most difficult. I was a blank sheet of paper. I had no idea and relied entirely on the evidence I could see from the clinical notes and applying my clinical experience and forming an opinion to the cause." He said he asked to have one case file to have an idea of what he was dealing with. Mr. Myers, on behalf of the defence, asked, "Was the phrase air embolus used at all?" Dr. Evans replied, "No. The first person to use air embolus, as far as I was concerned, was me. I need to give the NCA a compliment. They never gave me a steer. They are good, professional people." Mr. Myers turns to the case of child A. He asks that preterm babies such as child A are prone to complications. Dr. Evans replies, "That is why we have neonatal units." He adds that the care he received meant he had overcome the most difficult parts of his life and was stable prior to his deterioration. Mr. Myers asks if child A was, quote, "perfectly satisfactory prior to the collapse as according to Dr. Evans' notes." Dr. Evans says he does not want to engage in semantics, but adds that for a preterm baby in a position he was in, child A was satisfactory and really good. A clinical note is presented to the court with a number of problems listed. Dr. Evans replies, "I would call them issues, not problems. That is what any competent junior doctor would list as the issues present. We have got to deal with the fact he is preterm. He has breathing support, we need to establish feeds, there are concerns over suspected sepsis. Any doctor would write things down." An X-ray review is presented with the note RDS, Respiratory Distress Syndrome. Dr. Evans is asked about that comment. He says, quote, "I have seen the report. It's not too bad actually. That is why we put babies on CPAP." A blood gas record showing a high number for lactate, 2.6 outside the range up to 2, is shown. Dr. Evans explains he wouldn't be particularly concerned at such a reading, as he says 1 or 2 readings would be outside the normal range. He describes the reading as marginal, with all other readings normal, and child A was handling well. He said he would not interpret an oxygen reading from a capillary sample from a heel prick. He says if he saw such readings, knowing if the baby was in air, he would not be rushing to stick needles in him unless there was a change in condition in the baby. A NICU observation chart is presented for child A, including the respiratory rate. Mr. Myers says the readings are, quote, "not stable." Dr. Evans disagrees, saying the readings are, quote, "within range." The increase in the respiratory rate readings were down to the insertion of the long line and UVC, handling of the baby and a heel prick procedure which caused the baby discomfort. Dr. Evans said he would expect the heart rate to go up with an increased respiratory rate, which would be a concern. But as the heart rate had remained stable, he said he would not be concerned and child A was not even requiring oxygen, with saturation levels at about 97 to 99%, quote, "was about as good as it gets." Dr. Evans says it happens that children on neonatal units can go without fluids for 4 hours. He said it was not ideal and unfortunate, but it did not make a clinical difference in this case. He said a child which had missed out on that level of fluids for that time would not have subsequently collapsed and died. Dr. Evans reiterates that the context of other readings had all the markers of a stable baby. This was a baby who was stable prior to him collapsing, he said, referring to the words other doctors have made in evidence. Dr. Evans dismisses alternatives put forward by the defence, including infection, saying such evidence would appear on a post-mortem examination. He dismisses a suggestion of a rapidly spreading infection in the baby as ridiculous, as he said such evidence would again be found post-mortem by a pathologist. Dr. Evans said his conclusion of an air embolus was based on a baby suddenly crashing and, more significantly, followed by resuscitation, which was unsuccessful. He adds the subsequent X-ray and skin discoloration reports had firmed his opinion. He said, quote, "A collapse of this speed in a baby unit with full medical care is very unusual these days." He adds that child A, given all the factors, is normal and in the safest place on the planet for their needs. "Neonatal unit care is as good as it gets," he said. "It has come on leaps and bounds over the years." Mr. Myers, on behalf of the defence, says skin discoloration can be a sign of illness or due to underlying circulation problems, or infection or blood pressure issues secondary to something else. Dr. Evans agrees. Mr. Myers asks if it would be flawed to diagnose skin discoloration as an air embolus. Dr. Evans replies, "Discoloration is a general term, noting there is something present on the skin, as noted by a doctor or nurse. You can't say it is due to a specific condition." Mr. Myers refers to a 1989 study which showed following 50 cases involving an air embolism, only 11% involved skin discoloration. Dr. Evans said he had come to his initial conclusion of an air embolus for child A before becoming aware of the skin discoloration. The judge rephrases a question of Mr. Myers to ask that, quote, "Failure of resuscitation of itself and in isolation is not a consequence of an air embolus." Dr. Evans agrees. He says in combination with all factors already presented, including air in the grape vessels, sudden collapse and skin discoloration, the conclusion is that of an air embolus. He says an air embolus is not common but is rare and unusual. Dr. Evans said in 14 of the 17 cases he had completed his preliminary reports by November 2017 and was unaware of any medical staff member being a suspect. He became aware of the name LucyLetby for the first time upon her arrest in July 2018 when he read her name in the press. He said he was the first to come up with a diagnosis of an air embolus, and this had been agreed by a peer review by Dr. Sandy Bowen, plus by a medical expert who began to peer review his reports, but sadly before completing the review became seriously unwell and died. Mr. Myers asks about the non-fatal collapse of child B, who needed breathing support at birth, as clinical notes shown to the court shows. An X-ray review has the note RDS type picture, as also shown for child A. Dr. Evans agrees with Mr. Myers that a child such as child B is prone to desaturations. Mr. Myers presents a clinical note to the court from June 19th, 12 days after child B was born, noting there were desaturations recorded, and on June the 20th when the apnea alarm went off on 3 occasions, with oxygen saturation down to 70 to 80% on each occasion. A paediatric assessment dated July the 14th for child B is presented to the court, in which breathing problems are noted along with mottling. Mr. Myers states, "There are some respiratory issues associated with her health." Dr. Evans replies, "Nothing compared to what we would call the index event, the collapse. She needed resuscitating." Mr. Myers asks about the differential diagnosis for child B, concluding there was either an air embolus, suffocation, or someone had removed the prongs on purpose. Dr. Evans said in his opinion he was on the ball from the start in considering an air embolus. He said his opinion was reinforced by colour changes every 10 seconds, as mentioned by a Countess staff member in court. The theory of removing CPAP prongs on purpose is discussed. He says it's possible for a baby to move them by accident. He is asked if smothering is a possibility, to which Dr. Evans says he has since discounted. Mr. Myers, on behalf of the defence, said it is a key aspect that the inability to successfully resuscitate child A had led to an air embolus. He adds that child B recovered, and that is inconsistent and contradicts the air embolus theory. Dr. Evans responded, "No, it does not. We cannot do studies where we inject air into babies and see what happens." He adds that the volume and speed at which the air is injected, along with the skill of the resuscitation attempts, can make a difference as to whether the baby survives or dies. Dr. Evans says, under questioning by Mr. Myers, he would be happy to hear of an alternative explanation from a medical perspective for child B, but he is happy with the conclusion he has made for child B that she has had an air embolus. The prosecution refers to the clinical note from June 20th, following the desaturations recorded. The note adds child B, quote, self-corrected. Dr. Evans replies, "It's a bit frightening, but she self-corrected. These things happen in babies." He reiterates that those events noted on June 20th are a long way from what happened when child B suffered a non-fatal collapse.